Thank you so much to the organisers for actually allowing me to come and present this very exciting topic. How many of you have heard of the mobile stroke unit? Have seen presentation? Oh my goodness. All right, so I'm talking to the converted, hopefully. All right, so I must start by thanking all of our partner organisations, which includes the Stroke Foundation, as well as our philanthropic donors and other support bodies. So why do we need mobile stroke units? We know that time is brain, time is disability, and time is life. For every 15 minutes that we can pull back thrombolysis in an acute ischemic stroke patient, we save them 28 million brain cells. We give them back a month of extra healthy life, and we reduce their odds of mortality. So it's absolutely imperative that stroke patients are treated very, very quickly. Now, it's actually lovely to see that so much of today has been focused on stroke. I know that stroke is a very small portion of your overall workload, and truth be told, a lot of paramedics are not that interested in stroke because traditionally there was not a lot that you could do for them. You couldn't scan them, there was no treatments that you could give in the back of an ambulance, you were literally transporting them to hospital. And I say this married to a paramedic, and I know that his feelings on stroke. But stroke is now hugely exciting with the MSU and now with the Future Fund grant that Sharon was talking about before of nationalising MSU. So we're really in the cutting edge of medicine now. So this is really the premise of what the MSU does. So this is a infographic put out by the Stroke Foundation, and it shows you the 10 crucial steps to early management of stroke patients. So one is obviously somebody has to recognise the fact that their loved one's having a stroke or themselves. An ambulance is called, paramedics arrive on scene, treat the patient, begin transporting them to hospital, pre-hospital notification, the hospital activates a code stroke, the patient's met at the door by the hospital team and the code stroke team, they're taken straight for CT, they're diagnosed, and then step number 9 is where treatment starts. So out of 10 important steps in stroke management, treatment is 9 out of 10. So the whole purpose of the mobile stroke unit is to actually take the hospital to the patient. So we are not just a normal ambulance. We are designed to facilitate complete treatment on scene. So we are literally a mobile emergency department specific for stroke. So the aims of the MSU is to reduce cellular death, to reduce patients' death and disability rates, to provide more advances in pre-hospital triage by identifying those patients who need a comprehensive centre for either neurosurgery or clot retrieval, and that therefore that reduces into hospital transfers, and to provide earlier stabilisation and management of our patients. So the Melbourne MSU is a Mercedes 519 Sprinter, which is the same as the rest of our vehicles in our fleet, but it is the largest vehicle. We're staffed by a team of 5. We have 2 paramedics, one of whom's an intensive care paramedic, an advanced practice nurse, a radiographer and a neurologist. Now we are moving shortly to a fully integrated telemedicine model where the neurologist will be remotely consulting. So this is what it looks like. It's a box on a chassis, so our 2 paramedics sit up front. We then have the wall here that separates the cab and the chassis. We've got 5 seats here in the back, 3 seats here in the back for the hospital staff, so our neurologist, radiographer and nurse, standard striker stretcher, CT scanner, fully integrated into computer screens up here. What you can't see is up in the top screen here, just on the roof is a fully integrated telemedicine camera, which then shows up on one of these computer screens. The patient can't see it, but the rest of the team can. And then obviously we have various lockers for all of our medicines because we stock not only normal ambulance medications, but then we add the stroke-specific medications as well. So we launched November 20th, 2017, so we've been going for just over 20 months. We run Monday to Friday, 8 a.m. till 6 p.m. We're based at the Royal Melbourne Hospital in Melbourne, but we are fully integrated into all Ambulance Victoria services. So we're dual dispatched to all strokes, and this is important because most of the strokes that we get sent to, we don't actually even see. We're cancelled before we get there because the dispatch criteria is so vague for stroke that in the majority of cases our paramedics get there first and say this isn't a stroke and stand us down. So we need them to be going to those jobs to actually clear us early. The system auto-recommends us for acute strokes that have symptoms onset of less than 12 hours within a 20-kilometre radius of the hospital, but we can go anywhere within a 70-kilometre radius of what is referred to as Metro Melbourne, according to the AV mapping, if a crew requests us. So if somebody gets on the radio, they've gone to an unconscious or a fall or a chest pain and they say it's actually stroke, we'll go anywhere within Metro Melbourne. We can also self-dispatch if we hear a job on the radio that we weren't originally sent to. So as I said, we've been going for just over 20 months. We've seen just over we've been dispatched to just over 2,300 patients, which is about 6.5 calls per day. We're cancelled, as I said, 60% of the time we don't even get to the patient, which shows you how non-specific the AMPD, the dispatch tool is. And we've attended 900 patients. Of the patients that we see, half of them have a stroke or TIA diagnosis, with the majority of those being ischemic stroke. We've got about a 10% or 11% rate of hemorrhagic stroke, which is in line with what we would normally see in hospital. 7% of our patients are TIAs, and then we have this 17% of patients who are classified as an undifferentiated stroke, meaning that clinically we've diagnosed them as a stroke, but we haven't scanned them for a multitude of reasons, so we can't actually say if they're ischemic or hemorrhagic, but clinically they're having a stroke. Almost half of the patients that we see, we do a non-contrast CT scan of, and that is very highly sensitive to the presence of blood, which is this great white blob in the middle of the patient's brain here. It also allows us to see if we've got, there's our graphic there, allows us to see if we've got established changes of an ischemic stroke. About a quarter of our patients that we see, we do a CT angiogram on, which allows us to identify patients who have that large vessel occlusion. That means that they need clot retrieval. And the important thing out of this is 1 in 6 of these patients will bypass their closest stroke centre. So 1 in 6 of these patients would have gone to their closest stroke centre if we hadn't have gone to them, and they would have required an inter-hospital transfer. So that's actually quite a large number. Obviously, one of the main things that we want to do is thrombolyse our patients, and yesterday we gave our 100th thrombolytic treatment, which is really a big deal for us. And the important stat that we look at is of the eligible patients, that is, patients who have an ischemic stroke who present within 4.5 hours, how many of those did we actually thrombolyse? And we thrombolyse almost half, which is 10% more than the Australian average, so we are reaching more patients. If we're looking at thrombectomy, because obviously we don't have a mobile lab in the back of the ambulance, that's, maybe the next generation of mobile stroke units to come. But we obviously want to identify those patients who need thrombectomy and refer them to the right centres. So 63 of our ischemic stroke patients have been referred for ECR, which is 1 in 5. So again, 1 in 5 of our ischemic stroke patients would have had a delay if they had have gone to another hospital. We also carry blood pressure management, epileptic treatment, so we can give Keppra if they are having seizures. We can reverse their anticoagulation. We can give them a hemostatic agent, and we can also enrol them in clinical trials, which is a point of difference between us and some of the other MSUs around the world, where the MSU is in fact the clinical trial. We feel that if patients would have had the opportunity to be enrolled in a clinical trial in hospital, they should have it on the MSU. So what are our times? This graph shows you from the time of stroke onset to the patient's first engagement time with a stroke healthcare professional, be it either in the MSU on top or if they went to hospital on the bottom. So we are 26 minutes faster to seeing patients into their stroke journey than if they were taken to hospital. The green part of the graph then shows from the time that they're seen by a stroke healthcare person to the time of their CT, and you can see that they're basically the same time. And then the pink is from CT to needle time. So overall, we're 59 minutes faster. So remembering that I said that every 15 minutes that we save is 28 million brain cells, a month of disability, and a 5% increased odds of mortality. So we're now talking fourfold to that. That's the equivalent of 4 years of ageing in the patient's brain by pulling back that hour. So one of the things that we hear from some of our hospitals and some of our paramedics is, oh, but there's no need to keep you coming because we're only located 5 kilometres from the hospital. We'll just run them down to the hospital. But you can actually see from this graph, from this graph that what we refer to as our door to needle time, so that's this orange and green and pink bit here. So this is from the time that they first see a stroke professional to the time they get treated. We're over half an hour faster. So the patient could be literally having their stroke in the emergency department driveway, and we will still treat them faster than if they went through those doors and went into the ED. So no matter where the patient's located, metro versus rural, there is benefits to be had. So we often refer to door to needle time, which is from the time the patient reaches the hospital doors to the time they're treated, and we don't have obviously a direct comparison with the MSU, but we refer to scene to needle from our arrival on scene to needle. So they're not the same though. We're not actually talking about quite the same processes. So the things that have to happen to treat a patient in hospital, they obviously have to be triaged, they have to be registered, there's paramedic handover, there's initial patient assessment, because the triage nurse or the ED people must always redo the obs, even if you've done them in the driveway 30 seconds before. If they haven't got IV access and we need to get that established, they have to get to the scanner, have their scan. The scan has to be interpreted, a decision's made, and then finally the patient's treated. The things that are in our scene to needle time there's a lot more in it that's not representative at hospital, because this has all happened before the patient's got to hospital. So we have to get there. If we are second on scene, then we get a paramedic handover. We have to often establish the patient's name and address, because quite often we're arriving only 2 or 3 minutes after the initial crew. So a lot of these details aren't yet known. We've got to establish their past history, establish their meds. Often we need to make phone calls to family members or GPs to establish onset, and also if they're on an anticoagulation that might prevent them from being thrombolyzed. We've got to assess the patient, and then we start similar things, IV access. But one of the big things is extrication. You know, the hospital doesn't have to extricate the patient. They're wheeled into the ED. Most times we arrive, the patient's still on scene. They haven't actually moved out of the house or the building or wherever they are. Then we have our CT scan, interpretation, treatment decision and treatment. So if you remember from Sharon's talk this morning, only 30% of patients get thrombolyzed in hospital with a door to needle time of 60 minutes or less, which is the international standard. So we're really failing that department. On the MSU, 95% of our patients are treated within the first 60 minutes of us arriving on scene. And the only ones who aren't are usually quite obtunded and need airway intubation, or it's a severe extrication issue. So this graph is used a lot in stroke to show why and when we thrombolyse. So it's the odds ratio of patients being considered completely independent 3 months post-stroke, and it's basically showing the fact that their ability to go home independent degrades over time. The longer we take to treat patients, the less likely they are to be independent at 3 months. But if you have a look here, the graph starts at 60 minutes, because the thing is, we don't really know what happens if we thrombolyse patients in that first golden hour of their stroke onset, because for all of those things that have to happen for patients to be treated, nobody gets to hospital in time for that to happen. So it's a real unknown. That graph may continue being a gentle curve, or there may be an exponential increase. We just don't know how effective thrombolysis is in that golden hour. So that's one of the things that we wanted to look at on the MSU. So if we look at historical controls, the chances of patients being thrombolyzed in that golden hour in most hospitals is as much as 4%, and quite often it's as, realistically it's 1 to 2%. We've got a 3-fold increase in patients treated in that golden hour on the MSU. So 12% of our patients are thrombolyzed within the first 60 minutes, meaning that the likelihood is negligible damage has been done to that brain, and their chances of being independent at 3 months are significantly higher. If we do miss that golden hour though, almost half of our patients are treated in the first 90 minutes compared to 17% at hospital. So we are treating patients a lot faster. The other thing to look at for this graph is what the top green box here, this 9%. These are patients who are treated between 3.5 and 4.5 hours. Now, given the fact that the average Australian door to needle time is 72 minutes, if you as a paramedic see a patient at 3.5 hours in their house and you get them to hospital, they're not going to get treated. because they're going to see out that clock either on the way to hospital or during that daughter needle process, and they're going to time out. So that 9% represents patients who got treated purely because the MSU saw them, who otherwise wouldn't have been treated. So when we're looking at thrombectomy, there's also substantial time savings here as well. So if we look at our onset to groin puncture, so this is from stroke onset to the time that that groin's first punctured to do clot retrieval, the MSU allows patients to have ECR or clot retrieval 64 minutes faster. Now, that's not just a matter of us getting to them and us scanning them on site, but it also influences hospital processes. So this is door to groin. So this is from the time the patient hits those ED doors to the time their groin puncture starts, and we're faster here too. So by us seeing the patient, we're actually influencing hospital factors as well, because the interventionalists now know name, age, date of birth, patients pre-registered, they've potentially seen the images depending on what hospital they're working at. We've communicated to them via phone to tell them exactly what the patient's like, and the lab's ready, and we're literally wheeling in and through. So our fastest daughter groin puncture time so far has been 13 minutes, and that's because we didn't need to stop for any processes. In conclusion, I just want to say a couple of words about self-triage. So as I said, a lot of our patients we don't even get to see because they weren't stroke and our paramedics have stood us down. So we decided to run a little probability trial to see if we could improve this, our dispatch criteria. We can't obviously change the script, it's a licensed product, but could we affect who we actually see? So what we decided to do was we gave consecutive dispatched patients a stroke probability rating of high, medium and low, and you can see that it was highly scientific on the signs and symptoms. So patients with a high likelihood, we had some sort of limb weakness and cortical signs, meaning they were dysphasic or they had neglect. Patients with a low rating had very isolated or non-localising symptoms, meaning they had bilateral numbness or isolated facial droop or mild slurred speech. And as I said, highly scientific because the mediums were in between those. So, you know, there was a lot of scientific background going into this. So this was all based on the preliminary information given to us on our mobile data terminal. So 84-year-old lady with bilateral tingling in both hands feeling faint, or 30-year-old male with numb lips. So we would base it purely on that. It's not based on any information given to us by first on scene paramedics. So the majority of our patients scored low, followed by medium, and very small numbers received a high rating. Patients who were given a low stroke probability rating were far more likely, the MSU was far more likely to be cancelled before we got there, and very few of them had a stroke diagnosis if we saw them. If we compare this to the highs, we were far less likely to be cancelled, and they were far more likely to have a stroke diagnosis. And this purple graph shows the thrombolysis rate. So the higher their ranking, the more likely they were to be thrombolysed. So it shows that even based on that preliminary information, we can actually fairly accurately pick those patients who are stroke and non-stroke. We did choose to stand down from the patient who had numbness and vaginal pain. We did say that that was likely not to be a stroke. So our negative predictive value for thrombolysis patients in low cases is 0.91, meaning that there is still a small percentage of patients who, even if they have a low rating, will get thrombolysed. So if we did cancel ourselves off all of those low cases, there would be a few patients that we missed, but remembering that they're still going to go to hospital for a full workup. Our positive predictive value for thrombolysis in high and medium cases is 0.20. So this means that basically 20% of our patients with a high or medium rating are likely to get thrombolysis, which is about in keeping with what we'd find if they came to hospital. So in conclusion, the MSU substantially reduces our time to reperfusion therapy. We can save an hour for lysis cases and thrombectomy cases. We can improve pre-hospital triage, reduce the number of inter-hospital transfers required, but we do need to improve our dispatch criteria to optimise the surface. And obviously in the future, now that we have our funding, we'd love to see an expansion of the MSU service. And I would just like to acknowledge Henry Zhao, who is our medical lead, Francesca Langenberg, who's our radiology lead, all of our MSU team members, our paramedics, our executive staff, our receiving hospitals, and of course our donors and partner organisations. Thank you.